Good morning. Good morning. We are live and in color. Yours truly, Dr. Coop MD, here this morning for the inaugural launch of the PRIMO Health podcast. So a little bit about PRIMO Health. We are, I got to get you guys going on Instagram here. You're popping up and let's just see. It says to go live on Instagram. You would pop at the top of my feed, and I don't quite try creating a new Instagram feed. Okay, well, Instagram, I'm sorry, but you guys, hang on just a second here. I don't know what is happening here. Let's see here. All right. Well, I got the cure for that, which is exactly why I have my phone here, which is I'm going to go live on Instagram.
Okay. Are you live on Facebook?
Yeah. Oh, yeah. Live on Instagram and Facebook. So we are going to do that like that. Okay. Good. All right. Good morning, everybody. Once again, for that little technical glitch, this is Dr. Coop MD on air live Instagram. You were supposed to be streaming with me this morning, but I got a little glitch popped up here on my screen. I may not be able to see all your comments, but I certainly will be able to see most of them. Well, once again, I'm Dr. Cooper, Dr. Coop MD here. We're live and welcome to the inaugural launch of our PRIMO Health podcast. As you all know, PRIMO Health stands for Professional Resource for Independent Medical Opinion. So there we do specialty-based care. Many of you are clients of ours on the weight loss program. We also do virtual urgent care, meaning you can have access to talking heads like me 24/7, 365. It's not health insurance. It is a health benefit that you can sign up for on a monthly basis. What a product. Think about that. Being able to call a doctor anytime, day or night, for any kind of question you might have. Keep yourself out of the urgent care centers and perhaps even out of the emergency room for something that can be handled through a telemedicine platform. We also have virtual primary or direct care, a little bit more comprehensive and in-depth program, and also our specialty-based second opinions, where we connect you with specialists like myself and my guest, Dr. Lopez, for second opinions, help you make healthy decisions, very high-level decisions for you and your family members. So welcome you all this morning. I'm so excited about this topic. And let me put this out there right off the bat. The catch me was, let's talk about sex, baby. We're not, if you want to do all that, you can go on any of these, wherever else to talk about that with somebody else. We're going to talk about this from a sexual dysfunction and serious healthcare conditions that women face all the time. I became very, very acutely sort of informed, or much more informed and aware of these problems in women over probably the last 2.5, 3 years, particularly when we got into the weight loss arena. I realized that the 80 or 90% of the people that are clients that are women are suffering from all kinds of hormonal related issues. And some of them even reveal to me some of the sexual dysfunction and other issues that come along with that. And so today, I am very, very excited to talk to one of the world's experts in that area. My new friend, a longtime friend, but my new colleague, Dr. LaSonya Roberts-Lopez, who is a board certified urogynecologist and an expert on this topic. And we're going to get into it. We're going to get into it and really go in depth on some of the issues perhaps that most women, as I understand from Dr. Lopez and even some of my other physician colleagues, will not discuss with their primary care doctor. They will not discuss with other people. But when it becomes real problematic for them, they do seek out professionals like Dr. Lopez. So welcome, Dr. Lopez.
Hey, good morning, everybody. Hope everybody's doing well. Cool.
Awesome.
Thank you for inviting me to your platform. I'm super excited.
Awesome. Yeah. We're glad to have you.
Yeah, everything that could have gone wrong this morning happened. So I'm like, okay, this is going to be a good session.
Oh, it is
Yeah,
fantastic. So tell us a little bit about Dr. Lopez. Where you came from, what's your upbringing, background, what motivated you to get into medicine? Give us a little background on you.
absolutely. I'll be real quick so that we can get to
No,
the
take
meat.
your time. Take your time. We can do this again, by the way. We may need to have part two, you know.
We'll need part 2, 3, and 4. But
Oh, yeah,
anyhow,
good.
I am from Buffalo, New York, and I actually became interested in medicine when I was a child because I was born with a congenital heart problem. So I had frequent visits to my pediatric cardiologist, and I just remember telling my mom, one day I'm going to help other people like my doctor is helping me. So, I honestly thought I was going to be a pediatrician. That's where I started my journey, and ended up being a pelvic surgeon. So I got my BS in chemistry at RIT, and then I went to Emory for medical school. Subsequent to that, I did my OBGYN residency, came back to SUNY Buffalo, comforts of my home, and then came back to Atlanta to do my fellowship. And after doing my fellowship, I have had the opportunity to work in all arenas of medicine. I have done academics, private practice, and corporate medicine. And currently, I am pivoting in my career, and moving away from corporate medicine into more of a consultation and advocacy realm.
Awesome.
Um,
Tell me a
yeah.
little bit about the shift you in the background. I see that the neon sign there. Let's talk about that a
Absolutely.
bit.
Absolutely. That actually plays into everything that's going on with me professionally. What I was seeing is that, and you probably can attest to this, Coop, over the past, I don't know, 10, 15 years, we've seen a drastic change in healthcare delivery. And so we know what it was like, when it worked and when it really worked, and things are really changing. And I don't know, I would say didn't feel, or I don't feel that I had the appropriate time to consult with my patients. And I said to myself, what can I do to be more of an advocate, right? How can I pivot? That's where the concept of shifting came in. How can
Right.
you shift your mindset to establish the courage, right? To change from
Mhm.
something that you've done your whole life? Because, I've been wanting to do some type of shift, but we are trained that this is all we know how to do, right? So even though
Right.
most of us don't realize that our skill set can be used in other arenas in the marketplace, then we tend to just stick it out, regardless of if we have other aspirations. So
Yeah.
that's where the shift came in, and I had a conversation with my husband years ago, and then he was like, that's like a brand, because you can almost shift anything. And
Yeah.
then
Yeah.
really, yeah, I just started to embrace that. And I just figured, you know what? The first thing that we need to start with is shifting our mindsets.
Oh God, yes. Oh God,
Yes.
yes. I think, I mean, what you just tapped into something that I think we just need to talk about just a little bit, because the reality is that there's so many physicians like you and I, who, like you said, that 10 or 15 years ago, probably for me, even much further back than that, realized that, um, the institutionalization across the board of healthcare has really, to some extent, handcuffed and compromised the ability of physicians, I think, to deliver care in the way that it should be delivered. Okay. We're hiding behind brand names, big names. We're hiding behind white coats. We're hiding behind the veil of insurance companies, of big pharma, and all these other things. And we're being shackled with all kinds of requirements and things that very likely many of us who went into medicine did not expect that it would be that way. We felt like we would be able to have a very open, honest dialogue and relationship, quite frankly, in most cases, with our patients. And so I like the idea. I mean, I went through Shift U. I went through Shift U probably way before I left institutionalized medicine, because I started thinking these just thoughts just come in your head. It's amazing how your own creative energy comes out in the things that you think and say and do.
Well,
And even
here's
go
the
ahead.
thing.
Go ahead.
Here's the thing. We were trained
Yeah.
that medicine is an art,
Yeah.
and you start uh, having automation, right, to your thought process. You
Yeah.
remove that creativity and that art. Um,
Yes. Yes.
yeah.
Yes.
And so what's interesting is that if you think about it, with our training, we were used to shifting every 4 years, right? Because, you're at college
Yeah.
4 years, you're in medical school 4 years.
Yeah.
Then once you feel like you've gotten to the end or where the end of the tunnel, then you feel kind of stagnant. And so I think just changing to that automation just made a lot of us feel unfulfilled and that we were not providing the care that we could to our patients. So when I was in medical school and we were able to rotate through and, went through my Peds rotation, I did like it. But what I discovered was that actually I'm a surgeon, right? So my initial, after I was exposed to surgery, I thought, okay, I'm gonna be a trauma surgeon. And during that time, I realized that the adrenaline rush, the interest was there, but I did want to have more of a long-term relationship with my patients. So the mentor that I had at the time, she was the chief of the surgical ICU at Grady. She recommended, your last rotation is women's health. They have subspecialties, surgical subspecialties in women's health. Maybe you should explore that and before you make your decision. And so that's where I fell in love with urogynecology, right? So I was able to do my women's health rotation with OBGYN. And then at Emory, we were fortunate enough to have a fresh urogynecology program, because urogynecology actually is a young division in women's health. So, that's fairly new. We used to see a lot of gynecologists kind of overlapping on the urology side. So there's not a definitive fellowship academic tract at that time when I was in medical school. We were fortunate to have Lisa Peacock. She was there, kind of spearhead that. And that's where I got introduced and continued to pursue that.
Awesome. That's fantastic. So talk a little bit more about urogynecology. Give us, we know urine means the urologic system. Gynecology is more sexual related or sex organ related. So kind of give us, tell us a little bit about, in a little bit more depth, the convergence of those two and what that specialty, you said it was very young, really looks like.
Oh, absolutely. So with urogynecology, I think I coined the phrase that we are the gatekeepers of the pelvis. And the reason why I think people realized that it was important to have a urogynecologist is because you have all those organ systems in that small little space. And prior to having urogynecology, everything would be compartmentalized. But we know that when patients present with issues, that one organ system can affect another. And what I mean by that, for those of you who are not in the medical field, in your pelvis, you have your bladder, you have, your uterus, your ovaries, you have your lower GI tract, you have, muscles, a very vast vascular and neural system down there. And so when women would have, let's just use pelvic pain, for example, the initial reaction is to go to your gynecologist, which is correct. So you may go to your gynecologist, they do their workup, and they may say, you know what, your ultrasound is normal, your labs are normal, I don't see anything. And then they say, okay, well, let me just send you. Now I think people are getting familiar with pelvic floor physical therapy. But then, back in the day, they really didn't know what to do with that because they were so compartmentalized and focused on, gynecologic care or gynecologic etiologies. But as urogynecology start to develop, we realize, hey, it may be something other than your GYN organs or reproductive tract that can be causing this discomfort. And so I would say your urogynecology is a marriage between urology, just the lower urinary tract. So we don't deal with the kidneys. We don't deal with upper urinary tract. There's the lower urinary tract, your reproductive organs, your lower GI tract. But we focus on the entire pelvis. So your lower urologic tract, your reproductive, your lower GI, as well as the pelvic floor. So it's the marriage between urology and gynecology in general.
Got it. Let me ask you. So I remember just commenting, just thinking about this when I trained in general surgery in the 90s. We would get consulted on women with bladder prolapse. And all of these things, and we're just, I got no training in that, honestly. And I think oftentimes the only people we really could then get involved with that would be the urologist, who may not also, and then we get gynecologists involved. But there was really, there was really no, I guess, if you will, fusion of those things back then. So you kind of had all these people giving their little opinion from their perspective. And I'm not so sure, and I can understand the evolution of urogynecology, because I'm pretty sure that those women in the 90s who we were seeing were not really getting the kind of care that they deserve and that they should have gotten. So I just brought up one typical kind of thing that we see urogynecologists see, prolapse. Tell us about some of the other conditions, and then we'll go through some of those in a little bit more detail.
Absolutely. So first of all, let's just specify what prolapse is. So prolapse is basically where you can have descent or dropping of certain organs into the vaginal canal or through the vaginal opening. It could be your bladder, it could be cervix or uterus. If you've had a hysterectomy, it could be what we call the vaginal cuff, which is basically the vagina becomes a blind pouch if your cervix is removed. It could be your rectum, or it could be your urethra, which is the tube that urine comes through when it exits the body. And so that's what pelvic organ prolapse. And we have both surgical and non-surgical management options for those. Urinary incontinence is huge. That's probably one of the things that actually those two are probably the biggest things that we manage as urogynecologists. And it's important for women to understand that with urinary incontinence is not a one size fit all, right? So I've had patients come in that say, my friend had leakage, I want to go ahead and have the surgery. And I have to just slow them down a little bit and say, hey, let me just talk about the fact that there are different types of urinary incontinence. So if you have stress leakage and you leak when you're on a trampoline, that could be surgical intervention. But you have to go and I can't make it to the bathroom, that is not surgical intervention unless you do like a bladder pacemaker. I call it a bladder pacemaker. It's called InterStim. Okay. So I think that having forums like this is very informative so that people can come in just with a clean slate, clean mind and say, okay, this is what I'm having. Can we talk about potentially what's specific to me and not just have a generalization? So I love it. So
that's why we're here.
Absolutely.
Yeah. I'm sorry to interrupt you because you love to talk as much as I do. Let me ask you this, and I got so many questions for you.
Yeah.
So I do want one little promo announcement or an ask. All of you people over on Instagram or on Facebook, can you go post on your Instagram page to go to Facebook or YouTube to those people who keep coming in there? Because for some reason my Instagram audio is not working. I think it's because I'm using these headphones that only connect to one source. So you can see me on IG, but you can't hear me. So go to your Facebook or my Facebook page at Dr. Coop MD or on YouTube, and you'll be able to hear this. But it's a technical glitch. I'll fix it next time. So I do want to ask about this prolapse thing. And here's a big elephant in the room, and a question that I have to ask. I always thought that prolapse, leaking in urine and those kinds of things for women was a elderly woman's problem. I didn't know that this was a problem that even much younger women experience.
Absolutely.
So tell me a little bit about this age thing, because literally, I mean, I've always thought, okay, it's going to be a 75, 80-year-old woman who's, had, 6, 7, 8 kids or whatever in the past. But no, I mean, I've learned from you that these are issues that much younger women can also be afflicted with. Talk about that a little bit.
Oh, absolutely. So the thing about actually both urinary incontinence and prolapse is that they're multifactorial, right? And sometimes you really can't pinpoint with the patient what was the source or cause of their prolapse. So you have patients that actually have genetic predisposition, just the way their collagen is made. They may have never had a baby or anything. I remember clearly a patient that I had, I think she was in her 20s. And she never had children, no previous surgery, and she had prolapse. You have obesity is a risk factor. So, for those patients of yours who's coming on board with Ozempic, getting on a program, losing weight, changing their lifestyle would definitely help decrease the risk of either developing it or for it progressing.
Is there a BMI? Is there a BMI threshold for that where it becomes so you're moving along, you're gaining weight, your risk goes up, but is there one where you just it really catapults upward in terms
No,
of the risk? No, okay.
there's no specific number or cutoff, but we
Got
know
it.
that as the more weight you gain, the more your risk is, if that makes sense.
Okay.
So it's not like
Okay.
a BMI of 35 means you're going to get prolapse.
Okay.
And then patients who even have like chronic GI problems, say if IBS constipation, where you have to strain, people with repetitive heavy lifting, actually women who have long labors and not even, they may end up with C-sections, they still have risk factors for that. So the analogy that I give to my patients is that your pelvic floor support is like a hammock, okay, between two trees. And anything that puts pressure on that hammock can cause it to either stretch or rip. Okay. And so just think about a hammock. I think most of them have a weight limit of 300 pounds. If you're less than 300 pounds, you get on it, it'll sag. And when you get up, it'll go back to its normal position. But if you're more than that, it'll start to tear right from its attachment points. And so you sit down and you're just going to stay on the ground. So that's the analogy I give. But there are multiple factors. Yeah.
Yeah. Let me ask you this. What about multiple births? And is there a threshold there where you say, okay, 1, 2, 3, 4, 5 vaginal births? Does that increase your risk of developing a pelvic floor problem?
Yes, but again, there's no absolute number. So you know, there's no number of after your third child, and the only reason being is because there's so many other factors that can contribute to you developing pelvic organ prolapse.
Got it. Okay, cool. So let's move along here. So some of the things that we're talking about, pelvic prolapse and things like that. But now let's get into the sexual dysfunction that women, the problems that you see with women with pelvic or with sexual dysfunction as a urogynecologist. I looked up a bunch online. One of those things, which I think is probably underappreciated, is pelvic pain.
I was just
pain is probably number one on that list.
Yeah.
Some women do complain of the lack of sensitivity down there, and they can't have orgasms during sex. And then I also saw one here on my little list here. You know, some women complain about can't figure out a way to get rid of odor in their vaginal area and things like that. That then leads them to avoid sexual contact. So let's just go through some of those things that you see from a sexual dysfunction perspective that women suffer from. And I will say this, quite frankly, and maybe they're just suffering. I'll say suffer in silence, but I still think they do. But they just don't talk about it because it can be embarrassing and those kinds of things. But let's talk about those things a little bit.
Absolutely. I mean, even as a urogynecologist, and that being one of the things that we specialize in, women may not just openly come out and complain of that. That's something that we typically capture in our questioning, asking, do you have any of these problems? Probably more often than not. But before we get into dysfunction, let's just talk about what a normal, healthy sexual response is, because I think it needs to start from that. I think most people, when you hear of sexual dysfunction, the first thing that comes to mind is erectile dysfunction in men.
Men, exactly. Yeah.
You know what I mean? Or people say, oh, my girl, my wife, she doesn't feel like it. So those are the two scenarios that you typically hear. But in a normal sexual response, you have 4 stages, right? You have a desire, which is actually more linked to your interpersonal relationship, as well as some psychological and emotional components, like just the desire to even to have intercourse. And that can actually be affected by a lot of medications that we take, where there's a suppression in desire. And I don't think people understand that. Another big thing that we pick up on when we identify patients have that is a history of traumatic abuse. Yeah, that can be.
Wow.
And these things need to be discussed because, just think about when you're in a relationship and you feel like your significant other may not be attracted to you, and always say they're not in the mood. It could be something else that's going on. It's not necessarily the attraction or wanting to be with your mate. It could be something else that's going on. So
I want to just stop you right there real quick and interrupt Dr. Lopez, because I think that's something we need to come back to, because that's another topic that we need to discuss on this program. And maybe you could help me identify a guest that could come along with you, and that is sexual abuse. And we don't want to get into too deep on that, but I heard you loud and clear when you said, hey, that desire, listen to me closely, you all out there listening in the virtual world, that desire may be coming from past experience that has not been resolved as it relates to sexual abuse. And so that's something we need to talk about. And you and I will collaborate on getting that on a PRIMO Health podcast. I think we got to go in on that. But anyway, I'll let you continue. Go ahead. But I want to just emphasize that. Yes.
Yeah, absolutely. So we definitely need to come back and visit that. The second stage is arousal, right? So with stimulation, whether it's with you and another individual or you yourself, there are some physiologic changes that occur, right? You have increased blood flow to the genital areas. And this, I'm specifically speaking about women, right? We're not talking about men during this segment.
Absolutely.
Which leads to increased lubrication. You may see an increase in heart rate, and may have like vaginal spasms and all that, or pulsations, I should say. And whenever you have issues with arousal, typically, even if you have a desire, there's something that's stopping you physiologically, typically, could also be psychological, for having that physiologic response to stimulation, right? Okay. And that's called, female sexual arousal disorder. And then the next phase, which is actually the shortest phase in the sexual response, is your climax or orgasm. And that is potentiated by stimulation. It also, everything that I mentioned physiologically in the arousal stage is heightened. And you get to a peak where you get vaginal spasms. And then the last phase is resolution, where you pretty much come back to your pre-arousal state. So sexual dysfunction can occur in any of those stages, right? And then a tag onto that, which is probably one that I'll talk about in further detail, is the pelvic pain. So you can get anyone in those categories plus pelvic pain, which tends to be a huge culprit. Of all these situations, the one that is least talked about, because actually it's not that common, is when females do not have a good resolution phase. It's called persistent erectile. It's called, oh my goodness, why am I blanking out? Well, they persistently are stimulated or have a persistent orgasm. They can never resolve. And I don't think many people know about that. I've probably seen maybe one or two in my entire career, to be honest with you. And just to try to throw a little bit of humor in there, I'm pretty sure some of the guys are like, well, what's wrong with that?
I was not thinking that. I was saying to myself, I'm like, that's kind of like, what is up with that? Okay, anyway, yeah, let's get into that.
Persistent genital arousal. You're like, wait a minute, and so basically this can occur without any stimulation whatsoever. So it can occur with stimulation and it just never resolves. And so, I mean, it can really be detrimental to women's quality.
Is it painful? Do they complain of pain, or how does it manifest in terms of symptomatology?
I mean, it can. It's just usually described as discomfort. It's just a constant stimulation in that area. They can have spontaneous orgasms.
Oh, wow.
And it could really be debilitating. So that's something that, if you're out there in silence and it's happening to you, that is something that you need to discuss with your gynecologist or your urogynecologist, because there are management options for that. It may be like biofeedback. I don't know if you've heard of that with pelvic floor. And you would see a pelvic floor physical therapist. Sometimes will put you on some antidepressant medications that actually, it modulates your nerves, right? This is not for depression, but it can kind of rewire the nerves to the area to try to decrease the stimulation of the genital area. I'm sorry.
That's very complex, Dr. Lopez. I mean, you just described desire, arousal, climax, and resolution as the 4 stages. But at each one of those, and not that you can compartmentalize any of them, but I sit there as I'm thinking to myself, man, all of the things that go into kind of going through those in a normal fashion can be very, 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 very complex. And I mean, complicated. So, I just, I think about it in terms of, if I was sitting there as a doctor, somebody comes to me, I'm a heart specialist, and they got a heart problem. Okay. I got an algorithm that I go through in my head, and that, follows the, symptoms, history and all this other stuff. And we go through all of that physical examination, et cetera, et cetera. And then I try to come up with, but I'm sitting here thinking about this, like, man, you got to keep going back. Yeah, we do that. But man, this is so interrelated that every single one of these stages is intertwined in the symptoms, the history, the examination, and ultimately the treatment. So how do you approach a woman who comes in and says, I've got these issues and I just need some help. And you see them all the time. So how do you approach that? And what's your approach to going through sort of an algorithm in your head in terms of how we're going to attack this?
Oh, absolutely. So just like with any other condition or disease that we manage or face, a thorough history, I can't express that enough. And so what that means on the patient side is you have to really allow yourself to be vulnerable enough to give as much specific history as possible. Because we do know that there are multiple reasons that things occur. It's not just age, as you mentioned prior, right? It could be a medical problem. You a cardiothoracic surgeon. It could be, microvascular disease. It could be a neurologic problem that can cause it. It could be fluctuation in your hormones, whether it's surgical or non-surgical, or whether it was affected by a medication, right? You have chemo and things of that nature. It could also be any previous surgical interventions that have occurred that can affect your sexual function. Again, as you know, when we operate, we're disrupting some of the nerve complexes as well as the vasculature. So that can have an effect on it. And so getting a thorough history is prime, right? The next thing is obviously a very thorough GYN exam. Now, typically for urogynecologists, just because of the scope of our practice, our gynecologic exams are a little bit more thorough. I wouldn't say thorough. I would say in depth. Let me change my words, because it's not that gynecologists don't do thorough exams, because they do, but they're focused on, the conditions that they treat. So we have a few more steps that we do and things that we look at. And I'll give you an example, because I feel like most women feel, if they say, let's talk about pain, because you mentioned pelvic pain, right? I think this is a really good example to not only talk about one of the things that we treat and how our perspective of pelvic pain is different than maybe a gynecologist or a urologist, but also how it ties into sexual dysfunction. And you can jump in and ask me any questions as I go through.
I will. I'm letting you talk about it, because I am intrigued here. We're definitely gonna have to do part 2, because I realize at this point you mentioned it, we haven't even gotten into hormones. We haven't even gotten into
any of that. And the reason why I haven't spoken of that is because that's people's perception of why they have sexual dysfunction. And I want to know that is not the only cause. So we can circle back around and get to hormones, and that's
not in this one. I realized though, because you and I talking about this ahead of time, we were going to get into that, but that's a whole nother conversation, a whole nother podcast, and we're going to end up having to do a series of these. So I want, but to that point where you invited me to jump in here a little bit. I do want to say this. Let me just pause for the cause. Many of you out there who are watching this live right now, you're on PRIMO Health Podcast. I know y'all like hanging with Dr. Cooper, but this is the launch of our PRIMO Health Partners podcast with my first partner, Dr. Lopez. She is actually a urogynecologist. She's going to be available, and I need to put this out there on our platform at primohealthpartners.com. If you want to reach Dr. Lopez directly, you can reach her at her email. I think that's S. Lopez. Is that right? At primohealthpartners.com.
L. Lopez.
L. Lopez. Okay. What am I saying? L. Lopez at primohealthpartners.com. And the number to reach her, if you want to call, you're not going to get her directly, but you'll get our office, 404-217-7831. I will put that in the StreamYard chat. I think everybody can see that. So L. Lopez at PRIMO, PRIMO healthpartners.com, or you can just go to our website, primohealthpartners.com, and put a note in the chat, and then our people will get you in touch with Dr. Lopez. She will be available on our platform to go more in depth. I see a couple people have put comments out on some of the platforms about needing some help in this area, and a welcoming this conversation. So the sexual dysfunction piece, we men, okay, and all of these things I think apply. This whole thing applies to men as well, but we always tend to go straight to the issue, which is the end result, which is erectile dysfunction. Because of the way that this whole thing has been marketed and seemingly resolved with just popping a pill or taking a shot every day. But in this case, it's not that simple for women. Okay, it's not such a simple thing, and there's so many different other facets to it. When you start thinking about a treatment plan, okay. It seems to me, I'll tell you a couple things that came up initially when you start talking about how you go through the algorithm. You've got to establish a relationship, because I can tell you right now, I think most women, it's such a sensitive, personal thing, deeply personal thing that, they've got to be vulnerable, but that physician also has to be in a position to be very, very caring, compassionate, willing to listen, willing to take time. This is not a 15-minute.
That's something you can't teach in medical school.
Yeah, that's right.
It's something so that it's very important for.
Yeah, go ahead. Yeah, talk about that.
It's very important for patients to make sure that when they do, especially when dealing with women's health issues, which are very intimate, right? And there are times, a lot of times, when you don't feel comfortable even talking to close friends, and especially a medical professional that you may see once a year. So I think that, at least in my experience with my patients, that when we've met, they have felt an instant connection, right? And I think part of that is showing empathy. Number two is explaining to people on the level of where they're at. So what I mean by that is, if a physician comes into my office to see me, obviously the verbiage I'm going to use for that person is going to be different than someone who did not have any medical knowledge at all. And I think that creates a welcoming environment. So make sure that you're with a physician that is paying attention to you, a physician that you feel that is, being empathetic, and a person that is taking their time to explain, because it's complex for a cardiothoracic surgeon. So just imagine a person who's not in the medical field. But before we move on, I really want to circle back to the pelvic pain, because I feel that
please. Yes.
It is ignored. I've had family members, friends that have called me and say, hey, this is what's going on. I've been in pain for years. I've gone to my gynecologist. My ultrasound is fine. They're telling me nothing is wrong with me. I'm having heavy cycles. What is going on? That pelvic pain can lead to relational issues, sexual dysfunction issues. We, as your gynecologist, we look at your pelvis comprehensively. So we're saying, okay, where's this pain coming from? Is this pain coming from the bladder? Is this pain coming from the reproductive organs? Is this pain coming from the lower GI tract? Is it coming from muscles? Is it coming from some type of hyper nerve stimulation? Is it coming from the bony structure? So we're looking at the entire pelvis, going through our differential that is based off of your history and your physical exam. One of the things that we ask when patients are complaining of pain, pelvic pain, specifically painful intercourse, is, when does it occur? Like, does the pain occur with entry, with deep penetration, or after intercourse?
Okay.
Just answering those questions can basically kind of direct us towards what we're looking for on physical exam. And I'll give you examples. Say patients who complain of pain with entry during intercourse. We'll use that, okay? So think about the pelvis as a bowl, and the bowl is lined with muscles. And through the opening of that bowl are openings from the bladder, which is the urethra, opening of the vaginal canal, and then opening of the lower GI tract, or the rectum and anus, right? And so if you can envision that, muscles surround the vaginal canal. So if you have tense spasms of the vaginal muscles, that can basically close the vaginal canal and make a lot of tension so that when entry is attempted, it's not relaxed and it can't accommodate penetration. Does that make sense? And so
Got it.
in that instance, then we're looking at something to relax the muscles. We may give some type of vaginal cream or suppository that has a muscle relaxant in it.
Okay.
They may need to go to a pelvic floor physical therapist. And for those of you who are not familiar with pelvic floor physical therapists, there are therapists who specifically treat pelvic floor problems. So if you just go to a general physical therapist and they're not certified in pelvic floor health, that therapist is not going to help you the way you need to be helped, like if you have certification as a pelvic health specialist. Sometimes they have to go in manually and massage the muscle, just like if you had a spasm in your shoulder or your leg. Sometimes they have to do pressure point release. They may do vaginal dilators. So it's different things that, can be done. And so those patients may present with pelvic pain only if they're not sexually active, but if they are, they also may complain of pain during intercourse, right? So an example of a patient who may complain of pain with deep penetration would be a patient who has endometriosis or adenomyosis, which is a form of endometriosis of the uterus, because the reproductive organs have scarring. These implants from the endometrium, they respond to hormones, and it can create scar tissue inflammation and sensitivity for women. So with thrusting, if you're hitting the cervix, that's going to affect all that neural complex around the cervix and the uterus, and they can get pain from that, right? Okay. So that's another source of pelvic pain. And then the bladder. So, one of the things that I grew interest in is a condition called interstitial cystitis, which is one of the things I'm actually looking for when I do my workup for pelvic pain. And the thing about interstitial cystitis is it's a diagnosis of exclusion. And for
tell us what interstitial cystitis is, so everybody's up on
the same page. Absolutely. So interstitial cystitis.
Dr. Lopez, I got a buffering on your video. It's all good. Oh, so what's happening out there, Facebook and LinkedIn, and all of you people? I love you. Let me see. I'm going to put in the chat here. Sonya, you're buffering if you can hear me. She completely dropped out. All right, I think I'm still live. I think we lost Dr. Lopez. You're on with Dr. Coop, MD, on the PRIMO Health, the inaugural launch of our PRIMO Health podcast. And we were really getting into a really great discussion on sexual dysfunction, and particularly dealing with the issue of pain. And I'm going to see if Dr. Lopez is going to try to rejoin us. Hey, I see y'all out. Hey, Core Borders, my sister. Hey, how you doing? I still love you, but I'm gonna still get with you. You know that. Vanessa Kemp. Hey, what's going on, Ms. Kemp? How are you doing today? So good to see you, Sabrina. I see you up there. I saw your comment. We appreciate that. I'm gonna make sure that gets to Dr. Lopez, and you have the contact information. If any of you want to reach her at llopez@primohealthpartners.com. And also at 404-217-7831, our office number. You can leave a message, send us a text message, and let us know that you want to get an appointment with Dr. Lopez to discuss these important issues. We're not done with this. As you can see, there's so much to discuss as it relates to women's health in terms of sexual health, gynecologic issues. Most of the conversations out there are going to talk about heart disease and breast cancer. And I get it. I respect it. I understand it. But this is an area that is way underserved. And these are issues that are essentially not necessarily being ignored, but they're so sensitive and personal that people find it very hard to discuss them, to talk about them, to be honest about it. And then you saw from the conversation with Dr. Lopez how interconnected these issues are to perhaps sexual abuse. And we're going to have a whole nother Primo Health podcast on that issue. Let me just check in here with Dr. Lopez and see if we can get her back for a wrap up. And then we'll go from there. Hang on just a second here and see if we can't contact her. I'm going to see if I'm just texting her and see if she'll come back in just to do an outro and yeah, we're going to do a series on this. Vanessa, we're going to do a series on this. I appreciate Candy. Yeah. Hey, how you doing? Checking in. Sandy Peterson Cooper, my wife, PBG. Thank you that's Patrice Brown Greer. Thank you for checking in as well. Yes, we're going to do a follow-up on this conversation because clearly we're getting towards the end of the time. And I don't think Dr. Lopez can get back in for some of it. But don't worry about that. We're going to come back to this. We may even follow up on this within the next couple of weeks. But anyway, I think let me just give her another moment. This was good. We were going to get into a lot of different conversations around this. We talked about prolapse. We talked about sexual dysfunction. And in that topic, we were getting into the idea of pain, pelvic pain, as it relates to. Here she is.
We lost. I don't know what happened, so I'm not in my studio. So forgive me, but I thought that I should get back on for the.
So for the I was doing my best to ad lib, and but we're kind of getting close to the end here. So. I didn't really have any questions. I had a lot of great comments out there for you, in that regard. But I did want to just kind of get us to a point here where we can kind of wrap up. And so basically what we went through sort of some of the prolapse issues. We started talking about this pelvic pain, and you were at the point of describing interstitial cystitis, because I don't want to leave that wide open.
Oh, yes.
So tell us what that is. Tell us what you're interested in. Yeah.
Summarize that. So, and this is very important, especially for women who have issues with painful intercourse or pelvic pain. So interstitial cystitis is basically there is a disruption in the protective layer of the bladder. Unbeknownst to us, we're still trying to figure that out scientifically. But what we do know about what happens when you develop that is that there's some type of damage to the lining of your bladder. And then what happens is, because your kidneys naturally filters your blood and your urine is full of toxins and electrolytes and things of that nature, when the lining is intact, it does not communicate with what we call detrusor or muscle of the bladder. And that's where all your nerves and vasculature and stuff rests. When you have defects in that, then those little electrolytes and toxins can cross the barrier. And then it creates an inflammatory response that mimics a bladder infection. So if you're going to the doctor, you're saying, I have urgency, frequency, I'm having burning, and then they send your urine culture and it comes back negative, it's very possible that may be a condition that you have. And
stop right there. I'm going to stop you right there.
Absolutely.
Because you know how many times we see women who get, I got frequent urinary tract infection on antibiotics, it seems all the time, but it may be something else.
It could potentially be something else. So if you're having issues, and then I actually just got a question about this from a family member last week, where they came in with some symptoms. They tested their urine in the urgent care or either ER, I can't remember which, and they said I have an infection. Well, the difference with that, when you do what's called a quote unquote clean catch, for women, it's difficult because your vulva and your labia covers the urethra. So in in order to get a pure, clean sample, you have to be extremely cautious so that urine does not touch any of the skin around the urethra. So a lot of times when you get just a clean catch sample, you will see bacteria that's normal that presents on the skin, and then you're getting treated based off of the clean catch. That's why a culture then has to be sent. Or when you come into my office, I would do what's called a straight cath, where I'm in a sterile fashion, going in and draining the bladder so I can get a pure, clean sample where it does not touch the labia. So if that comes back with bacteria, a high white count, that's more than likely an infection. You still send it for a culture, but even if that comes back negative, you can still have this other condition, because you still will get white blood cells, right? Because the inflammatory reaction. You still get red blood cells because of the vasculature that's interrupted. So just make sure if you're presenting like that, that is a discussion or question you may have for the
So one of the
thing.
Right. So one of the comments I have from my sister from back home, Cora Borders, is that, so how do you truly make the diagnosis then? I mean, is it a diagnosis of exclusion, or do you have a test? Okay, I see. So you're going through the steps, Cora Borders, to rule out, and then you have to decide. Now, is there imaging tests, ultrasounds, or any biopsies perhaps that can help delineate if it's truly interstitial cystitis?
No true imaging studies, cystoscopy potentially, but we know that interstitial cystitis, there's it's a continuum. So it depends on where you catch it in the phase. Your cystole may be normal. So the goal of your workup is to rule out the bad stuff. You want to rule out bladder cancer. You know, the most common thing, you want to rule out a urinary tract infection. So once you've gotten all that, you look at the history and you look at the previous labs. You on physical exam, they may have tenderness when you palpate the bladder, when you do your vaginal exam. There are other things clinically that can help you ascertain the diagnoses, but you're correct. It's the diagnosis of exclusion. But I just want that to stick into folks' heads, because oftentimes females are being told that their workup is negative. And this is actually what made me go into Urogyn ultimately after the exposure. When I was in residency, there was a young lady who was in her 20s having pelvic pain. Of course, being a resident, you don't have the final say. My attending said she needs a hysterectomy, right?
Yeah, blow it out. Yeah.
Blew it out, got a hysterectomy. She still had pain. And they sent her to a psychiatrist because they said there is no way that you can still have pain if you've had a hysterectomy. And because of my experience with urogynecology at Emory, I knew that they did not do a full workup. And so for some of you women with pelvic pain, before you even consider having a surgery, make sure your workup is done properly. And even for endometriosis, for example, that doesn't.
You don't know. I got to interrupt you, Dr. Lopez. Let the church say amen. Oh my goodness. You have no idea. And I know these people. I know a lot of the people out here that are commenting. These are sisters, my sisters that I know. And I can tell you right now, they are going to spread this word like crazy, and people are going to hear that message. And thank God for you, because, as I told you 2-3 years ago, I said, LaSonya, I don't know what to do when these women come on our platform and they want to be on medicine for weight loss. And then we get into discussion. I have to ask, where are you in the, many of them in the menopausal cycle, and what are the issues are you having that may be contributing to it, and trying to be a thorough evaluation of what's leading to some of the other. And let me tell you something, 100%. I say, man, I don't know. I have to just be honest with it. It's out of my area of expertise. And then I know that they have these issues, and they're not willing to discuss it with a talking head like me, which they shouldn't, because I'd be up there rambling. But they know one thing Coop won't do to them is lie to them. And I've been telling them all along that I'm going to have somebody on my platform who can handle this. So I hope you're ready, Dr. Lopez. We're about 5 minutes from our hour to blow up. I'm claiming exclusivity. Okay, for a period of time. I'm claiming exclusivity, because let me tell you something. When people see this, they're going. First of all, you're going to see all the other podcasts out there start wanting to talk about this, like we're doing. Okay, that's the first thing you'll see. And they
Well,
gonna
I
bring on
will
their
definitely talk about it on mine.
yeah. Absolutely. Absolutely. Yours is yours. But I'm claiming exclusivity. Do y'all leave Dr. Lopez alone because she's mine? We're not even anywhere near being done with this conversation.
Not at all.
So I think we need to stop right there.
Do you have any questions at all?
Yeah, any questions coming into the comments? Cora Borders put in one question. We asked, how's it truly diagnosed as a diagnosis of exclusion? We were talking specifically about interstitial cystitis, okay, as a cause of pelvic pain. And so if there's any other questions real quick that we can address, we will. But I've already put out there the your contact information. Pam Green, GRC. I give it Sheila Jordan Brown. Thank you, Judge. Sheila Jordan is our Director of Clinical Operations at PRIMO Health Partners. You all, that's the number I put out there. She's like, "Oh Lord, you're gonna blow me up."
Cool. Let's actually talk about the services that I'm gonna provide.
Yeah. Let's do that. Let's do that real quick so that we can get into this. Yes.
Yeah. So we can
wrap up. By the way.
Okay,
yeah.
that's fine.
Go ahead.
So I will be providing virtual services on his platform. Accepting patients that I will manage virtually, but also second opinions. So if you feel like you're going on a hamster wheel, you're going in circles, you've been dealing with some type of women's health issue and you're not getting answers and you're having persistent symptoms, please reach out to me. The one thing I learned during COVID when we had to we had to modify how we managed our patients. And what I learned, and the reason why I'm passionate about this, is that I had to do a lot of my patient care virtually. And so what I learned was that 15 or 30 minutes that we would have scheduled in the office to have you checked in, vitals taken, history taken, the physician going in, talking to you, examining you, giving you a diagnosis, and then discharging you. We had to do that in 15 minutes or either 30 minutes for new patients. But with virtual, I sit down and talk to you the entire time. What that allows us to do, not just establish a relationship, but for me to go more in depth with what is really happening and connect some dots. Like you would be amazed at other things that come up in those conversations that we just really wouldn't have time to talk about in the office. I can thoroughly go through my thought process. So the same way we're talking about pelvic pain and interstitial cystitis, I can have a conversation individually with you and say, this is why I'm thinking this. These are the tests that I'm ordering and why. And then we can go over a list of things, and then I can give you literature. We can talk about it. You can ask me whatever questions you want. And I feel that when you talk about these women's health intimacy issues, that is the type of service that you need in order to get in a comfortable space, in order to, live a healthy sexual life, healthy pelvic health life.
I am sitting here just overjoyed with Grace, because it's very emotional for me, because I've got 3 girls and a wife. And I know one of the things that you do is naturopathic kind of stuff as well. Yeah. And you're very, very big on that naturopathic solution. So this isn't about Dr. Lopez just trying to do some surgery on you. In fact, she's not even going to do that. But if you decide you're going to go under the knife, you need to speak to Dr. Lopez before you do that, and make sure that you have gone through all the proper steps and all the check boxes have been checked off before you actually do that. And in addition to that, PRIMO Health Partners, independent medical opinions, we'll send you to anybody. We're not tied to any insurance company or whatever. We're going to send you, if you need heart surgery, for example, we're going to send you somebody that we trust and know and respect, okay? And we're going to give you, guess what, our independent medical opinion. So reach out to us. We're not done yet. LaSonya, we got to figure out part 2 here, because
we have to. I'm sorry. I don't know what happened with our connection. So we missed.
Oh, no. Don't. Let me tell you, it was that was just a pause for us to like absorb all this, because I was like, wait a minute. We really only absorbed and only scratched the surface, quite frankly, on some of the things that we need to discuss.
So I probably will do, guys, for all the listeners, I'll probably do a series on my Shift You podcast. And Coop, we can also collaborate and do some stuff, because there is tie-in with the medication you're prescribing as well as with your subspecialty.
Correct.
Cardiovascular disease.
Oh, and we didn't even talk about the effect of diet. I tell you, I saw, and then this is one out there, a little, a little graphic, but I saw a bunch of women out there talking about pelvic or vaginal odor and stuff, and how to deal with that in a naturopathic way. But there may be some other physiologic issues that need to be done. But wait a minute now. You ain't taking this to Shift U. We gotta finish this.
No, we're gonna do both. We're gonna do both, but I feel like that platform will be great to.
Oh, it will to integration.
And I can do absolutely no. It's not.
We're married up now, LaSonya. We married up now. This thing is. I'm so excited because this has been a subject and something that I've been thinking about, and I feel so incapable, quite frankly, of having the discussion. Last thing I want to say here, we're going to wrap up. PRIMO Health Partners podcast. This is our inaugural lunch. Dr. Lopez is now my partner on the PRIMO Health platform. You can reach her at primohealthpartners.com. L. Lopez, you can email her at primohealthpartners.com. You can call our office, leave a message, text message 404-217-7831, and to connect with Dr. Lopez that way. And you can also see her on our virtual platform as a patient to get a second opinion, to talk through some of these issues, going back and forth to the doctor, getting antibiotics, and it could be something totally different. So,
and we can explore natural options.
Absolutely. And then we also want to get into, the whole idea, your whole Shift U, which is really a much more holistic. Hey, look, I want to thank you all. Our time is up here today for being on the podcast. I really appreciate you. I love you. There's nothing you can do about that. And I want you to encourage you to share this with all of your friends, all of your women friends. And I also want to encourage you along the way to share this information with your partners, because, one of the things I think is so important is to have open, honest discussion in a partnership, particularly as it relates to sexual dysfunction. It's not just about erectile dysfunction. There's the other side of the coin. So with that, we're going to wrap up. You all have a fantastic Saturday. Love you again. And we look forward to reaching out to you very soon. Be on the lookout at Dr. Coop MD, also on PRIMO Health Partners, for our next segment on this very important women's health, gynecology, and sexual health related issues. You all take care. Have a fantastic weekend.
See you. Thanks again, Coop, for inviting.